Okay, so good morning. Welcome to this early morning session. I think it's going to be a very interesting and challenging session because the concept we are going to deal with is very exciting. And some of you saw yesterday during the Shark Tank session. It's going to be very exciting how to combine, the duodenal exclusion and other way of excluding duodenum. So the topic is bipartition and intestinal bypass due to the standard or flush in the pan. Who knows? We want to try to define and to clear up some concepts regarding this issue. I'm the chair of the session. I have the two co-moderators, Professor Randeep Baldaham from India and Professor François Patou from France. And of course, I'm going to talk, as you will see, the first talk. The moderator can, it's not necessary to introduce myself. I'm going to, Professor Antonio Torre, I come from Spain, and they're going to be my topic. Can I have my slide, please? The session will run the following way. After my presentation, the co-moderator will guide us to all the session, and I think it's going to be much better to have the discussion at the end of the session, and maybe all of us can discuss about that. Okay, let's start with the concepts of the transit bipartition and intestinal bypass. What is the physiopathology and surgical principles? Is that working? Oh, yeah, it's working. But I cannot see here the presentation, right? Now it's okay. Okay. This is my disclosure, and this is the summary of the different bariatric and metabolic surgery procedure. We have now at present times very different surgical alternatives. Some of them are related with non-diverted gastric sleeve, and going to be the sleeve gastrectomy itself. Some other are diverting the jejunum. As an example, the Roux-en-Y gastric bypass. Some other, I'm going to divert the ileal region, maybe the one anastomosis gastric bypass, the distal Roux-en-Y gastric bypass. And finally, we have some of them that will diverting mainly the ileum, the duodenal switch, the SADIS, the transit bipartition, SASI, and the ileal interposition. So we are going to focus in this last procedure. But in the end, this surgical alternative that we are dealing with this today are, in my opinion, the huge advantage of preserves the pylorus at the same time to stimulate the ileum from a metabolic point of view. It means that there are more physiological surgery than other that you were using at the present time. I think, this guy, Sergio Santoro from Brazil, was the pioneer in showing us in bringing up with this concept that the sleeve gastrectomy with the transit bipartition. In the very important public paper he published in Annals of Surgery in 2012, he described the concept of this procedure. It's going to be to do a sleeve gastrectomy and a transit bipartition, Roux-en-Y transit bipartition. This procedure was designed to avoid mechanical restriction, malabsorption, excluding segment, and the complete loss of some intestinal function like a duodenum and the jejunum. It's the initial idea. Here in summary, the different part of this concept, sleeve plus bipartition. The restriction going to be getting a decrease in the intake of the regular sleeve, and also inducing the satiety due to some, communication between the brain, and also very important, stimulating the ileum in a very early way, going to be increasing the secretion of many incretin hormones, GLP-1, PYY, fibroblast growth factor 19, and then also excluding the proximal jejunum is going to be to decrease the secretion of GIP and the glucagon. It's going to be the consequences of don't stimulate the proximal jejunum. This is the standard duodenal switch. As you can see, the Roux-en-Y duodenal switch. This is the transit bipartition. Can you see the differences? Roux-en-Y transit bipartition, right? And in the end, we are getting the same distal stimulus with these two procedures, duodenal switch, transit bipartition. And then, in this sense, not excluding, the duodenum and the proximal jejunum, and kind of be facilitating the total endoscopic access to this area, even the common bile duct, and of course a minimal nutritional problem because the food will be two ways, one to the duodenum and the other one to the ileum. Of course, from the technical point of view, it's going to be theoretically much more easier and safer anastomosis. The gastroileal anastomosis at the beginning, following Santoro's proposal, was 250 from the ileocecal valve. There are some changes. At the beginning, the length of the anastomosis was 3 centimeters. We can discuss later on with the different expert speaker we are having here. At the present time, they are performing the anastomosis between 200 and 230 centimeters from the ileocecal valve. The numbers of the result that Dr. Santoro presented at present time are very exciting. A exit weight loss at 5 years is 87%, and 81% the exit weight BMI loss at 10 years. In the median of the patient, their preoperative BMI was 41. In the end, going to be very similar result to the DS in this scenario. Regarding the comorbidities, type 2 diabetic remission, 85%, 87%, improving 12, and non-changes in 0.1%. Regarding, this object, is going to be having, without a complete duodenal exclusion, just a duodenal, taking out from the duodenum some food that are going directly to the ileum. Regarding another comorbidity, arterial hypertension, very exciting result, 85% remission, 14% improvement. Also, from the dyslipidemic point of view, the remission high triglyceride 91%, very, very exciting, of course. There are a very interesting paper that Philippe Topard in France comparing a standard Roux-en-Y duodenal switch with a transit bipartition. In this paper, as you can see here, they compare 71 patients with BPDDS and 71 patients with total transit bipartition. And here you can see in the demographic characteristics, the patients submitted to duodenal switch are a little bit heavier regarding the BMI and the initial weight of those patients. And here you can see the result regarding this comparison between those procedures regarding the percentage of BMI loss, the total weight loss, and the BMI in the end. And you can see a very similar, a little bit more powerful, the standard duodenal switch, Roux-en-Y duodenal switch, but in the end, very, very, very similar. So the results are 1 year only. You could wait a little bit more long term, but this is the 1 year paper. But the most interesting, in my opinion, the most interesting finding in this paper is going to be the adverse effect and the quality of life of the patient. You can see here that the percentage of patients under total bipartition with less than one daily movement is going to be 41%, compared with 11% of the patient under duodenal switch has more diarrhea or more number or bowel movement. The conclusion of this study by Philippe Topard is that the transit bipartition are getting very similar results regarding weight loss, the control of comorbidities. I must clear up. 1 year of follow-up, but with less adverse effect, mainly quality of life of the patient regarding the diarrhea of the patient. So, but again, there's another proposal. It's not perform just one Roux-en-Y transit bipartition, but perform one anastomosis transit bipartition. This idea, here you can see is a leak gastrectomy with a transit bipartition, just one anastomosis, excuse me, this is the classical Santoro procedure, Roux-en-Y transit bipartition, and next you can see the SASI procedure. It means transit bipartition with one anastomosis, gastroileal anastomosis. It's called single anastomosis sleeve ileal, the SASI procedure. This procedure initially was launched by Professor Tarek Mahdi in Egypt, and he presented this data in 2018, these 521 patients with a very, 92% of remission of their diabetes and other comorbidities, 70% hypertension, hypertriglyceridemia, hypercholesterolemia, and type 2 diabetes in 95% of the patient. And here's a very exciting paper published very recently by Rui Ribeiro from Portugal, dealing with one anastomosis transient bipartition in those patients. They're going to be 68 patients. Going to be very interesting. Going to be, in the end, is something very similar to the standard MACD procedure. The BMI, median BMI of the patient by Dr. Rui Ribeiro is 41. And here you can see the differences between, there are two different common channels. They are comparing 200 centimeter common channel with 300 centimeter common channel. Here you can see the total weight loss 5 years, going to be a little bit in favor, but very similar result. You can see the total weight loss 5 years comparing the 250 with the 300 centimeter. Here you can see the numbers and the figure over there. And here more closely regarding the different control of the lipidemia, of the lipidemia, here you can see that 250 length of the common channel is going to be a little bit more effective regarding the control of type 2 diabetes, hypertension, dyslipidemia, but again, 300 is going to be also getting very nice result. And finally, there is a very important meta-analysis literature review performed in China, comparing these two procedures. In the upper part, the standard, excuse me, Roux-en-Y transient bipartition, and down the one anastomosis transient bipartition, means the SASI. Here you can see the different authors, and here you can see the different numbers, total weight loss, 27%, 44%, 20%, regarding the standard Roux-en-Y, and regarding the SASI, very similar, 36%, 27%, and 31%. So very similar, one anastomosis transient bipartition and two anastomosis transient bipartition. Regarding, in the same meta-analysis, the same regarding the comorbidities, again, up the standard Roux-en-Y transient bipartition and down the one anastomosis transient bipartition, regarding the control of type 2 diabetes, hypertension, and other very exciting results, as already said before. But now we have another option, how not to think about the duodenal bipartition. This is going to be to perform duodenal ileal anastomosis. Now we are here, Dr. Gagné, he will deal with that, but see the theoretical advantages of this duodenal bipartition are the early stimulation, going to the ileum earlier, partial derivation of calories, main duodenal absorption, access to the main bile duct, and decrease the bile result. We have performed a study. He will deal with that just to show you, the scheme. He will do that better than me later on. But in the end, we are getting, this is after performing the anastomosis, in the end, we will perform a sutureless and non-bowel opening procedure. It's going to be, after that, we can do many things, as you will see later on. This is the way that the various bolus, you can show after the operation how the food is going through the ileum and it's going also through the duodenum. It's going to be very nice how we're going to be in this. This is post-pyloric anastomosis. Is a first page, we'll say, OSADI procedure. And in this end, we present this result. Dr. Gagné will go deeper later on, but we have in this paper published in surgical endoscopy, 24 patients 6 months and 6 patients 1 year the follow-up with a very interesting result regarding total weight loss, accepted weight loss. And we are a couple of weeks, we're commenting with Dr. Gagné, we are publishing our Madrid experience with this patient, and here you can see the 1 year follow-up, how result regarding the total weight loss and the accepted weight loss at the BMI of the patient 1 year after performing the duodenal diversion, the magnetic duodenal diversion, as you will see later on. And here you can see the result regarding hemoglobin A1C in our patient, very, very exciting result, having the food passing through the duodenum post-pylorically and through the ileum. So, transient bipartition, sleep plus 1 or 2 anastomosis. Okay, who knows? There is typically, the expert, the surgeon are performing this. They usually say that typically 7 to 80% of the food goes to the ileum. all limbs are alimentary limbs. I don't think, you know, there's no doubt that we can access endoscopically to the duodenum and the bile duct, but I don't think, you know, this approach of 70 to 80% is really, we can say that. Regarding the size of the anastomosis, 3 centimeters, 4 centimeters, going to be depending, going to be narrowing, going to be closing, going to be facilitating the pass for one or the way. Again, we don't know what is the exact root of that. And finally, bipartition, to whom and why? Well, I think this operation was designed to avoid a huge malabsorption, a huge absorption, but is theoretically less hyperabsorptive than the standard duodenal switch, less hyperabsorptive than the standard SADIS, less weight drop probably, less metabolic effect. Another issue that we can argue is that we have creating a lower pressure sleeve and facilitating controlling to having a less GER after the operation of this. And I'd like to invite you to our next European chapter IFSO meeting in Venice, from the 15th to 17th of May next year. And thank you very much for your kind attention. And then, you know, Professor Fatou, Adib, your turn.
Thank you. Thank you, Professor Torres, for setting the stage for the session. Next, I invite Professor Francois for his talk on transit, bipartition, and intestinal glucose absorption.
Well, thank you very much for the invitation and for the early birds to be here very early this morning to listen about this talk about molecular things. So I hope I'm not going to lose you. I will have only 10 slides. I will go slowly to walk you through. So this is intestinal glucose absorption we are going to talk about. So you might know, or you might remember, this is an extraordinary thing that was discovered a long, long time ago, decades, that glucose is absorbed very selectively in the intestine through this SGLT1, which is a cousin of this SGLT2, which is in the kidney for the new drugs for the diabetes. And this thing is just a little red little transporter on the tip of the intestine enterocyte who carries the glucose together with the sodium. So you need 2 sodium for 1 glucose and it's active. And you can have as much absorption as you eat glucose. There is no limit to that, or nearly no limit. So on the right thing is, yeah, it was moving, you saw it a little bit. So it's a little PET scan where you have put some FDG, but orally. This is not the way we do it in clinic, of course. This is a rat. And here you can see that, obviously, all the glucose is going in the blood, and you will find it, this component in the bladder at the end of the day. It's glucosuria. Okay, so now it's very difficult to measure glucose absorption in human, because glucose, as soon as it's in portal vein and systemic circulation, is absolutely taken up by insulin action, by the tissue. So what you see in the blood in terms of glucose concentration doesn't tell you anything about absorption. It tells you about the full picture. So it's a big mixture. So it's difficult to have an idea of the glucose absorption just by looking at glucose. So we are using, and you should look that name, it's going to be, I think, big in the coming years, xylose. It's an old story, but we have just rejuvenated it. And so dexylose is a pentose, which is absorbed the same way as the glucose, same transporter, but it's not metabolized. So it stays in the blood, and you can measure it. And if you just measure it very simply, you'll see what is absorbed. And so you can see it's a series of meal tests in 100 patients, where you can see that the more glucose is absorbed on the left, and the more the glucose will go up after the meal. And the correlation is quite good. But just the long story short, xylose is a biomarker, easy to measure in human, of glucose absorption. So the story we did 10 years ago is about looking at, with these tools, looking in mini pigs and then in man, about the glucose absorption effect of gastric bypass. So again, long story short, you can go to the paper, but it's quite clear-cut. So glucose needs sodium to be absorbed. And sodium doesn't come from the food. The food has little sodium. The sodium comes from the bile. You don't know, but bile is super salty, 3 times the concentration of the blood. So the food is just arriving in the intestine, swimming in bile, perfect environment to be absorbed. After a gastric bypass, the bile is diverted. There is no food and bile in the alimentary limb. So nothing is absorbed unless it comes to the common channel. it's a little bit confusing in the literature because no one realized that it goes from the stomach pouch to the bottom anastomosis in like few seconds. If you look in X-ray in the X-ray room, you'll see that. So what you see in this test, biological test, is just few minutes and you don't capture it at all. What you see in the very first minute of OGTT is what happened in the common limb. So, and that's an example of that. So if we now look at these gastric bypass patients, it's before and after surgery, gastric bypass, with a mixed meal including xylose. You have exactly this demonstration where xylose, because it's clearly a biomarker of absorption only. Of course, you have this bottom curve that everyone knows where glucose goes super up in the beginning because it goes straight to the jejunum or to the intestine where it's very much absorbed very quickly. But if you look the area under the curve, at the end of the 3 hours after the meal, the quantity of xylose, and you can see that up there, is much lower than before gastric bypass. So again, the bottom line is that gastric bypass is decreasing glucose absorption when glucose comes from a meal where it has to be digested. This is not the same with the OGTT. You don't drink glucose like that normally. It's a non-physiological test. But if you do a mixed meal test with complex carbohydrate, that's what you found. So here my point is that gastric bypass decreases glucose absorption, and of course the cinetic is different, but overall the glucose absorption is decreased. And so let's come back to our point. So what happens with this new operation? So on this very simple graph with color, it's easy to see that all these operations, they are saying the same, You are just changing the anatomy. Some of them, you just do nothing, like the band of the sleeve. You just do a little bit of stomach, but you don't do anything to the intestine. But the other, you always do the same. You have an alimentary limb, a common limb. Sometimes you don't have an alimentary limb. And there's this new bipartition. So if you followed me, glucose absorption goes with the blue, with the common limb. So we know that as long as the common limb, the blue one, is going shorter, glucose absorption will decrease, postprandial glucose excursion will decrease, and diabetes will do better. And that's why duodenal switch is the best operation, because the common limb is so short. Bipartition, that was puzzling. What happens? Because you don't know exactly where it goes, so it's not obvious. So that's why we wanted to see that. And so that's now the last part, and that's the new things. It's just not published, but I think it's interesting to share that with you, and I was asked to do that today. So this is the story of a randomized trial, which is ongoing in France, Robert Caiazzo being the PI. So this study, as you heard about the Omega, this is the next one to come in a row of 5. And so this one, now it's finished, the enrollment, so it was flying in France. So we compared bipartition, the central operation, with gastric bypass. So it's ongoing. I'm not going to tell you the end because we don't know. We have to wait for the follow-up. But what we did, is for 12 patients, 6 each, we did meal test, this same meal test I showed you, before and after surgery. So you are going to see what is happening there. So, I'm missing some little thing that was on my computer, but that's okay. This is just the shadow area. So, but the line is the mean, and the interrupted line is the dispersion, the confidence interval. So what you can see here is that before you have the 2 operations, so Roux-en-Y is red, bipartition is green. Before operation, this is randomized trial, they are exactly the same, they are nearly the same, 6 patients only, so it's a little bit different, but it's not significant at all. But after, you can see that there is a major difference, and it seems that xylose absorption is much less after a bipartition. So there is much less. There is less absorption, and you don't have this very rapid glucose or xylose absorption in the beginning. And if we now look at the glucose and insulin, that makes sense. So sorry, because it was much easier with the shadow area that disappeared between there and here. But so what you can see before and after is blood glucose, of course, was the same before, but after you have the typical red change. Gastric bypass, you have this burst of glucose, and then it goes down. And you can see down the insulin response. This is why when the burst of glucose is firing, insulin is then responding, and then that's why there is hypoglycemia, because then you have too much insulin, there is no more glucose absorption, so insulin arrives when there is no more glucose, there is no need for it, and it's hypoglycemia. But in the green one, you can see that there is much less of this rapid glucose absorption, We can discuss why. There is much less insulin first. And so that means that there is less absorption of glucose. So that's the big picture. So at the end of the day, it will be better for glucose, for sure, for diabetes. But it's also interesting that there will be, I'm pretty sure, there will be very few hypoglycemia because of that. So this is it. So this is my answer to the question I was asked, so that transit bipartition reduces intestinal glucose absorption. And I think these data clearly show that. And I will, of course, be happy to discuss and answer a question a little bit later. Thank you for your attention.
Yeah, the next one. Thank you, François. Next, I invite Dr. Surendra Ugale from India for sleeve plus sleeve jejunal bypass 5-year multi-center results.
Very good morning to all of you, and my thanks to Antonio for this invite. Happy to share our experience of sleeve and sleeve jejunal bypass, also known as SASJ. I have no conflict of interest. So is this the new kid on the block? In the bypass group, if you see the RYGB and the OAGB, there was the gastric area that was remnant and there was no biliary access. Then we looked at the sleeve plus group. You had the sleeve and DJB and the SADI. There was dissection of the duodenum going up to gastroduodenal artery, but no biliary access again. In the Santoro's transit bipartition and the SASI, it's become an effective sleeve plus bypass procedure. There is endoscopic and biliary access. It's surgery in the gastric region, and revision was much easier. But there was a much higher incidence of serious nutritional side effects, especially with the SASI, because of the extent of the bypass. So we felt the safer and the better option is to do a proximal operation of the same type, so going onto the jejunum. So if you look at the nomenclature, SASJ, as it's known commonly, is the single anastomosis sleeve jejunal bypass, just like the SASI, which is single anastomosis sleeve ileal bypass. And so this could be a form of one anastomosis transit with a bipartition, whether you have it proximal on the jejunum or you have the distal one on the ileum. In this procedure, as you can see in a simple manner, you do a regular sleeve and you anastomose a loop of the jejunum at a distance that is decided upon in surgery depending on the total length of the small bowel. Now in the procedure, we use 6 ports laparoscopically, staple sleeve with a 36 French gastric bougie. The jejunum is measured and marked at 100 or 150 or 200 centimeters with 2 limb sutures, depending on the total length of the bowel. Small bowel is measured proximally from ileocecal valve. And we want to ensure that there is a sufficient length of the common limb, more than 300 centimeters for sure, and preferably more than 400 centimeters. Because in our earlier work with the SASI procedure, we found that when the bowel lengths were 250 or 300 or 350, some of the patients were fine, but some of them had major nutritional issues, including nutritional cirrhosis. And then we do a anticolic staple anastomosis of the marked jejunal loop to the antral end of the sleeve. We didn't believe in the constricted anastomosis of 3 centimeter, which Santoro had suggested, because we saw with the work in other units that every now and then there would be a stenosis of the anastomosis. And if there was a stenosis, then it acts just like a sleeve. and you lose all the metabolic, all the effects. So we decided we'd maintain just like an MGB, 45 millimeter firing. Enterotomy is closed with PDS, and a leak test is always done with methylene blue. And the Peterson space is closed always with a continuous 3-0-proline suture. So the first step is a standard sleeve. You can see we do an antral resecting sleeve, which is 2 to 3 centimeters proximal to the pylorus. Then we bring up the loop of jejunum and anastomosed as described earlier. So this procedure is maintaining your biliary access, avoids transaction of the duodenum. It creates a bypass that is functional to achieve the weight loss and resolution of the metabolic syndrome, and aimed at making a bypass procedure that is easier for most bariatric surgeons, including younger surgeons. So it combines the ease of a sleeve with the widely accepted OAGB, MGB, and the benefits of a bipartition using a loop anastomosis. In the data we have, we have a multi-center data from 3 centers, and here you can see the mean BMI is 45. Diabetes was there in 65% of the patients, with a mean HbA1c of 7.5%. The inclusion was that BMI had to be more than 30, at least 12 months follow-up, and was a primary surgery. The follow-up was quite good at 3 years of 80% and 5 years of 68%. Now the bowel lengths that we have measured during surgery, and this is our appeal to all surgeons, that when we want to do a scientific procedure, you need to measure bowel lengths if you're doing a bypass. And you need to close all gaps. So that's why the bicentric gap is acceptable to everyone, but the Peterson space is not yet. So here you can see the total small bowel length range from 530 centimeters to 1035 centimeters, and the common limb from 330 to 835. When we looked at weight loss, if you look at the total body weight loss at 3 years was 40%, maintained at 5 years. Remission of diabetes was 97% and 91%. Now, surprisingly, as was shown earlier also in one of their slides, there was no reduction in weight loss efficacy even with a longer limb of the common bowel. So when you look at the 5-year weight loss, the total body weight loss, you can see whether you have a common limb of 400 to 500 or even more than 800 centimeters. The weight loss we had was ranging between 39% to 43% as the total body weight loss. In the uncontrolled group where HbA1c with diabetes was more than 8, you can see that the mean HbA1c in that group was 9.6, and it ranged from 8 to 16. Insulin usage was in nearly 60% of the patients. And at 3 and 5 years, you can see a very good resolution of diabetes and no usage of insulin at all. There was a nutritional stability, knowing that the duodenal route is also available. It is a fact that in the first few months, probably when radiological studies are done, and maybe 80% goes to the anastomosis, but usually after 3 months, we have seen that most of the food will go through the anastomosis, a little bit depending on the volume of the food. Some might go in the duodenal route. But all the nutritional factors were really well maintained. We especially had to watch the hemoglobin and the iron, which fluctuated a bit and sometimes required supplements. In complications, there was no mortality in this. The main problems we had is 2 patients who had dumping, hypoproteinemia and hypoalbuminemia, and they didn't improve with any of the conservative measures that we used. So we went in for a partial reversal, as we call it. You disconnect the anastomosis and you maintain a sleeve in place. So this is another factor which is much better than the other operations where you would need to revise the whole thing. And we have a publication in place with data from 3 centers. We have now expanded this. This is a study that has been accepted by our Indian Bariatric Association. And now we have a total of 8 centers in place which are contributing to this. Then when you compare this with a sleeve alone, you can see that the total body weight loss is different significantly. Diabetes remission also is different. And in literature search, of course, they said MGB had shorter operating time, better weight loss in this study, better comorbidity resolution. But both groups had comparative results and safety. And in this study, the sleeve and jejunal bypass had better weight loss, while the MGB had better diabetes resolution. This in publication by Sefevi has shown that even as a revisional procedure, it was effective in diabetes remission and in resolution of comorbidities, improvement of comorbidities. When you compare it, the weight loss at 3 years in this study at 40.7% was better than sleeve alone or RYGB and sleeve and DJB, but comparable to the OAGB. Diabetes remission of 97% at 3 years was better than sleeve alone, RYGB, OAGB, and jejunal ileal interposition. This was a group-matched study that we had done of 41 patients in each group, a group with sleeve, OAGB, the SASI, and the sleeve jejunal bypass. And in this we found that the percentage of total body weight loss was surprisingly better with the SASI and the sleeve and jejunal bypass at 3 years as compared with OAGB and the sleeve groups. All the methods of bypass and sleeve, they can be performed safely with good results, but this SASJ has the added advantage of maintaining biliary access and the option of partial reversal while maintaining a sleeve. This was group-matched study of OAGB with the SASJ, since OAGB is the more popular bariatric bypass procedure being used. Nutritional stability was equivalent. The control of weight and diabetes resolution, there was a marginal, it was marginally, was better with the SASJ, but not very significantly different. In some of the other published data, they've shown 1-year results which were comparable, except this one publication from El Rafai which showed 56% total weight loss, which seemed exceptional. So what were we looking for? We were looking for good weight loss. Here we got 40% total body weight loss at 5 years, good glycemic control and remission, endoscopic access to all areas, and easy revision or reversibility. Thank you.
Thank you, Suren.
Thank you.
Next, I invite Dr. Mark Magdy for his talk on SASI versus SADS updated results.
Good. It's the magnetic, so that's the other. Sorry, wrong talk. Sorry, the AV guy, that's the wrong speech. That's the, it's a concurrent session, but if you put the other slides up, that'd be great. Still looks good.
Yeah, maybe that's
Yeah,
better.
probably,
Okay.
yeah.
Maybe
I'll
that's
stop
better.
So, yeah. We invite Professor Michel Garnier for his talk on duodenal bipartition concept and clinical options at the present time.
Thank you very much. I think you heard Professor Torres giving some introduction to this concept. These are my financial disclosures. I started in 2007 to look at this concept of doing duodenal bipartition. And at the time, we were looking at trying to make a complete endoscopic procedure with a compression anastomosis device in the duodenum and one coming with a colonoscope into the ileum and doing a complete endoscopic procedure. And these were the early experiments that were published. And you can see here on the first picture, we perform in the animal because in the pig, the ampulla is right after the pylorus, and you cannot make an anastomosis like in humans between the pylorus and the ampulla. It's just not technically possible. And so we did an anastomosis that is post-ampullary between the duodenum and the ileum. And these are excised specimen. You can see here the pylorus, the duodenum, and the ileum anastomosis side to side with compression anastomosis. And this is the endoscopy picture of the anastomosis without any sutures or any staples. And compared to control, these are growing animals in pink. They were growing their weight versus the animal who had the bipartition, where they maintained kind of their weight as these were growing smaller pigs. We were worried about effect on biochemistry and effect on the liver, and we did liver histology. There was slightly central lobular granularity as described by the hepatologist, but we did not see fibrosis or other effects on the liver. And biochemistry, we look at all the at 60 days, 56 days, and there was no derangement in anything with this experiment. We also had, the histology of the anastomosis and alignments of the submucosa, and so forth. In 2008, we submitted this idea, and this patent was accepted by the American Patent Office that you could do by colonoscopy and bringing a magnet either in the colon and the duodenum and also through the ileum and the duodenum to perform an anastomosis between the two. We therefore had the concept that duodenal anastomosis with self-assembling magnets was an idea. When our early experiment ended up having square magnet, this is 4 magnets that were forming a box with the magnets being in the channel of the endoscope. We quickly thought that it was not possible for us to make more robust and large anastomosis, especially like in the stomach, with such a concept. So we decided to come out from the channel of the endoscope and go outside the endoscope and have these larger magnets for anastomosis. And therefore, this is the first generation, is a 3 centimeter long magnet with a groove that permits the anastomosis. And so these are redone experiments from 2007, 2008. We redone them with this new generation device and between the duodenum and the ileum in the pig. and have obtained good result at 6 weeks. This is the duodenum and this is the ileum. You can see the color is slightly different, but the anastomosis is quite pristine without much adhesions with a compression and anastomosis as compared to the suture enterotomy where there's a lot of scar tissue from an absorbable closure. And this is the endoscopic picture before autopsy at 6 weeks. And you see 3 lumens. You see the natural duodenum, and this is the ileum with both lumen. You have to understand that when you do the endoscopy in a pig, you have to go 360 degrees in order to enter in the pylorus, and the image is upside down. That's why the duodenum looks on this side, but it's naturally on the other side. And again, by endoscopy, the image is pretty good of alignments with duodenum and ileum, with the serosa, submucosa, with very little inflammatory reaction. With this, we embarked on human trial, and the side-to-side duodenal ileostomy is a duodenal bipartition in such that we maintain an opening in the natural duodenum, right post-pyloric. We try 1 to 2 centimeter post-pyloric, and we were afraid of getting into the ampulla area or the accessory pancreatic duct. So this is something that is not visible when we place the linear magnets. But with a 3 centimeter magnet, we don't think we are going to encroach in this. And it's different than a single anastomosis duodenal ileostomy because all the food goes through the ileal loop and the duodenum is closed. So this is providing access to the natural duodenum. It provides an absorption of minerals and vitamin B and C complex, and it's easily reversible if the patient has a problem or you don't like the anastomosis. And the idea is to provide a stimulation of the ileum, which releases PYY336 and GLP-1, and sort of being on Ozempic all the time, this stimulation of ileum, and also a decreased absorption of glucose, calories, and fat with a shorter ileum in play. So this is a cartoon showing the side-to-side anastomosis and compression, and it's reproducing a linear anastomosis stapling with closure, but the compression happens over several weeks, and then they pass, the magnets will pass into the distal ileum. So the first 5 patients were done in Tbilisi, Georgia, with Dr. Abuladzi's team at the Innova Medical Center. And we had to deliver the distal magnet by short colonoscope into past the ligaments of Treitz, where we had a laparoscopic magnet device to transport this to the marking at 250 centimeter. And the second endoscopy was providing the duodenal magnet, and they were docking together with closure of the mesenteric defect, the Peterson's defect, to avoid an internal hernia. So there are no sutures holding the duodenum and the ileum in place. Nothing holds it except for the magnet themselves. The position of the magnets in each of the first 5 patients, in the first in human, they were 5 patients, and you can see they're all in the right upper quadrant as a pair. Duration, this was done in combination with a sleeve gastrectomy. So the magnets were positioned first and the sleeve gastrectomy was done after, so that we don't have derangements, we don't have a torque force of the endoscope on the staple line. Anyway, this is 3 years, 1 year later, and you can see a drop of weight, a drop of body mass index, and in percentage of excess weight loss, it reaches 80% at 1 year. The complications were quite minor in grade 1 and 2 classification, DINDO classification. You know, like positive COVID was recorded as a complication, but we have to record everything. And the hemoglobin A1C had dropped to a level of 2 of drop. You can maintain at 1 year, and glucose down also. We then embark on a multi-institutional study involving 4 countries, like the team of Dr. Torres in Spain, the team of Dr. Cadier in Belgium, the Canadian team in Montreal, and the Tbilisi team in Georgia. And we've had multiple studies, but in order to summarize, the percentage of excess weight loss of the patients who had sleeve plus anastomosis was reaching 86% of excess weight loss. If they were performed after a sleeve gastrectomy, they reached 27% of excess weight loss. This was with the first generation device of 3 centimeter. There are more publications, like Dr. Torres' team, our team in Montreal, and the team of Belgium also published their own result. Now, the interesting thing about the Belgium studies is they've done a lot of endoscopy to follow up the anastomosis, because we had many questions. Did the anastomosis remain open at 1 year and 2 years? These are all the 10 patients that were operated, and you can see that from the natural lumen of the second, here we're getting towards the second duodenum, the anastomosis is right after the pylorus and is always posterior and inferior. If we look at results that are 2 years, 1 year, 2 years later, the anastomosis is maintained, and we've been able to do 5 of the 10 patients that were able to come back and agree to get an endoscopy, and these anastomoses are still maintained. Now, this is the first generation with a 3 centimeter device, and we are going to 4 and 5 centimeter device to get even larger anastomosis between the duodenum and the ileum. So the second question is, how much is going through that anastomosis? So you can do barium studies, and it's imprecise, because most radiologists will say, oh, it's about 50% that goes through the anastomosis. But Dr. Cadier in Belgium has done an isotopic study with marked yogurt with technetium 99, and was able to calculate the flow in the ileal loop goes between as low as 7% to 32%, average being around 20% in his own cohort of patients. Now, I know he's done SASI, and the percentage is between 80 to 90%. So that is the difference, and why they're getting better result with a SASI than with a duodenal anastomosis. So it's dependent on the prepyloric pressure to push down the material down the ileum, and so we need to make longer anastomosis in the duodenal ileum and a shorter, probably, anastomosis in the stomach to get a percentage that might be more equilibrated towards the 50%, 60%, in my opinion. So we are obtaining this by using now a 4 and a 5 centimeter swallowable magnet. This is beside the Allurian balloon, and we're doing the study in Georgia and in Canada in type 2 diabetes patient without any gastrectomy, so just the anastomosis between the duodenum and the ileum. In Tbilisi, we've done 15 patients. You can see the body mass index is 30-35. They're all type 2 diabetic, and we have had an average body mass index of 33, 53% of female with a mean age of 53 years old, and we have 100% alignment, 100% patency, 100% swallowable, and the median expulsion time is 24 days, which means that the anastomosis is before 24 days, usually around 21 days. We've had up to 54% excess weight loss at 1 year with just a anastomosis between the duodenum and the ileum. And we've been able to drop the hemoglobin A1C close to 6.4. At 1 year, the numbers are small, but we need the total 15 patients to see if we're going to go below 6 in these patients, with minor side effect and a procedure that is between 30 minutes to 60 minutes to do by combined endoscopy laparoscopy. So patent anastomosis, more than 50% excess weight loss at 1 year. It's promising for type 2 diabetes, but we're early in our results, and more than half of our patients have reached an hemoglobin A1C less than 6.5. Thank you very much.
Thank you. So, Mark, are you there? Okay, okay. So we'll move on to the next talk, primary one anastomosis, transit bipartition, Dr. Ala Wafa.
Hello everyone. I have to thank Antonio Torres for allowing me to present here in such an outstanding meeting. I'm Ala Wafa, bariatric surgeon from Libya. Here I will present a primary one anastomosis transit bipartition, how I do it.
It's better when they, yeah.
It's not. It's not working. Okay, I have no conflict of interest. This is our publication at Obesity Surgery Journal, which is an alarming rate of malnutrition after single sleeve ileal bypass, a single center experience, where we explain our experience with a 30 case of SASI procedure with obesity grade 3, was a primary metabolic bariatric surgery procedure, and our result was high rate of malnutrition with 23.3% of severe hypoalbuminemia and hypoproteinemia. Those patients need revision from SASI to sleeve gastrectomy, and we receive a letter to the editor with more than 2 letters of editor that explaining maybe the cause of this malnutrition is related to our surgical procedure. So here I have to thank Antonio Torres to allow me to present how we do our SASI procedure. This is one of our cases, 39-year-old female patient with BMI 55.5, no comorbidity, no reflux, all preoperative lab was within normal. This is our port site, it's similar to that of SADI procedure. We have 5 ports, 10 millimeter, 12 millimeter, and 3 5 millimeter trocar. And here we start our video. After we make port insertion, laparoscopic exploration started. We identify the cecum, the ileocecal junction, and we measure about 300 centimeters from the cecum as a common channel, and we didn't measure the whole bowel limb length. After we finish a measurement, we put a clips proximal and distal to the bowel to prevent any mal rotation. After that, we fix the bowel to the gastrocolic ligament. With just one suture. Then we proceed for the usual sleeve gastrectomy dissection, and we dissect the omentum away from the greater curvature of the stomach, and we proceed forward proximally toward the left cross of diaphragm, as usual, as we did in sleeve gastrectomy. Furthermore, we go distally toward the pylorus. We dissect the antrum up to the level of the pylorus. Then, after we finish our dissection, we measure about 6 centimeters from the pylorus. Both by the grasper and by the stapler. And we start our vertical sleeve gastrectomy 6 centimeters from the pylorus. Over 42 French bougie, but we make the sleeve wide. We are not tight on bougie. Followed by oversewing of the stapler line with non-absorbable suture. Then we make our gastrostomy, followed by enterotomy, we insert the linear stapler and making the gastroileal anastomosis, and the size of our gastroileal anastomosis is about 4 centimeters. So after that, we close the gastroileal stoma using 3/0 barbed suture. And after that, we add more second layer of interrupted 3/0 BDS. And here's the second layer of the BDS. And after we finish our gastroileal anastomosis, we insert the bougie through the gastroileal stoma and make sure that there is no any narrowing. And we conclude our surgery by making a leak test. And this is the final view of our surgery. Thank you so much.
Thank you. So next, we call once again Dr. Surendra Gale for bowel measurements and gap closures and intestinal bypass.
Yeah, can you play the video? I play the video. Okay. So here you can see simple ways of measuring the small bowel. So we use graspers which are either we have some graspers which are marked with laser with a 10 centimeter mark. There are some other graspers where we have taken off the insulation, and so we have it marked again at 10 centimeters. So it's a very specific way of doing the bowel measurements. The closure of Peterson's space after doing an anticolic anastomosis, when you lift up and flip the bowel onto the left side of the patient, the loop anastomosis, go to the base where the opening is and take sutures with non-absorbable sutures. This is 3-0-proline that we use. One can use the barb suture, I guess that makes it easier. So fix a knot at the base and then can take side-to-side sutures with the mesentery of the bowel and the fat that exists there along with the colon. And in this manner, one can travel up and close the whole gap that exists with the Peterson space. When you do it in this fashion, if you ever have to go in later, a final suture is this serosal suture, which holds the bowel there in place. And if you ever have to go in later for any other surgery, you'll see that the whole opening remains closed very effectively. There is no twist in the anastomosis. The lie of the bowel is good of the loop anastomosis. And as opposed to the 6 centimeter space which was left in the SASSY video you saw, we do a regular antral resecting sleeve, so our anastomosis is posterior to the staple line. Now, closure of mesenteric gaps. Any bowel anastomosis, once the anastomosis is done, if you lift the anastomotic, the suture area, you can see where the gap lies. This is the mesenteric gap. And there you can see the mesentery in the bowel from the other side. When you see that clearly at the base of this, we take a purse string suture. Again, this is 3-0-proline in a continuous fashion. You go all along the base, go to the opposite side, and they are not very superficial sutures. And then you come back to the first side, go to where you started, and then tie the knot. Now, at times when you take bites like this, you may encounter a little bleeding, but as soon as you tie these sutures, the bleeding always stops. So that need not deter you from taking good bites. And then you take side to side. Once the base is closed completely, you take side to side sutures and you close the rest of the gap. Usually you need one purse string base suture and either 2 or 3 side to side, and that effectively closes the whole gap. Now, when you have any procedure which involves a retrocolic opening, you can see this is a duodenal-ileal anastomosis where the gastroduodenal tube is brought retrocolic. So this is to take a fixation suture to close the retrocolic space, the mesenteric gap there. You take continuous sutures along the base, then on the wall of the stomach and back onto the mesentery. And you tie that one suture which closes this part of it. And then you need one more anterior suture which picks up the mesentery, and you take a serosal stitch on the gastric wall. And once you have done this, this completely closes that gap. And the rest is, as you saw in the previous mesenteric gap, this is to just floor the gaps. Here you can see where the anastomosis is. It's a triangular space that is seen. So we start from one side on the bowel, go to the base, then come back on the bowel and come to the original spot. And when you close this, it completely closes that space. So basically, it was just to show how you can effectively close this. And so if some surgeons want to avoid closure of Peterson space, then they might think of doing, if they have rule limbs for anastomosis, they could do retropolic, and then you can have an effective closure like this done in a very simple way if they want to avoid a Peterson's space gap closure. So this is mimicking, again, it's a different site of anastomosis, but the principle is the same of flooring the gap. Make sure you don't get any of the intestinal loops in a twist by pulling onto any side. So the important thing is the gap has to be identified very clearly, and then you can do this very safely and effectively. I think I'll stop it there. Thank you.
Thank you, Suren.